Hello, very good evening. Today I'm to discuss about reversing cardiac remodeling with heart failure treatment. Uh, Worldwide, heart failure is a global burden, and a large number of patients are suffering from heart failure with its significant impact on mortality as well as morbidities. It has been seen from several studies that more than 37.7% of the worldwide uh, the heart failure has a significant prevalence value. And by 2030, the number of heart failure patients will rise by almost 25%. At the age of 55 years, the lifetime risk of heart failure is 33% for men and 28.5% for women. Almost 17 to 45% of the deaths occur within 1 year of diagnosis. And in India, the data are almost same. Almost 20 to 25% of the cases with a newly diagnosed heart failure dies within a year. Therefore, it has a significant impact on uh, the life expectancy as well as the quality of life. The heart failure in Indian scenario is a little bit different as because we do have a more number of aging populations as well as increased prevalence of coronary artery disease, increased rise of key risk factors such as hypertension and diabetes, persistence of diseases like rheumatic heart disease and untreated congenital heart disease. And it has been seen from several studies from India that the Indian patients presents at heart failure a little bit earlier. And the male is to female ratio is also different in India, 70 to 30. Rheumatic heart disease is also a major contributing factors. And diabetes mellitus is much more prevalent among Indians. Prognosis of heart failure in Indian patients appear to be worse than those in the West. And these factors should be kept in mind whenever we are treating heart failure patients. Now coming to main topic of remodeling. What is basically remodeling? Remodeling is an adaptive process in the cardiac myocytes when any kind of cardiac insults occur. Initially, it was described following myocardial infarction, the ischemic insults to cardiac myocytes, which leads to loss of myocytes, elongation of myocytes, slippage of myocytes from a different plane, as well as certain biochemical alteration in the cardiac myocytes. And ultimately, they lose the contracting and the relaxing properties, which ultimately affects the LV geometry. It assumes LV spherical shape that leads to functional mitral regurgitation, and the symptoms of heart failure gets aggravated and the cycle goes on. And here comes the concept of reverse remodeling, that if we can reverse this remodeling process, which are maladaptive, then the patients will get a significant benefit in the treatment of heart failure. And in the long run, they'll be significantly symptoms free and the prognosis will be improved. And that is why nowadays the targeted therapies are more concerned about the reverse remodeling. This cardiac remodeling is associated with an increased risk of cardiovascular death as well as heart failure hospitalization. And the reverse remodeling can be assessed by the imaging technique as well as certain biochemical parameters. The initial studies showed that the biochemical parameters like NT-proBNP, highly sensitive troponin, galactose-3, soluble ST2, to all are associated with this improvement in remodeling process, as well as certain imaging parameters in echocardiography like LV and systolic volume, LV and diastolic volume, A-level of index, and of course the LV ejection fraction, all are associated with this reverse remodeling. And by these parameters, we can assess that the reverse remodeling is happening or not by prescribing certain drugs, by implanting certain machines like CRT. So the variable predictive parameters of reverse cardiac remodeling like this: non-ischemic heart failure, reduced ejection fraction, shorter heart failure duration, female sex, absence of LBB, left bundle branch block, guideline-directed medical therapy that includes beta blocker, ACE inhibitors, mineralocorticoid receptor antagonist, as well as after paradigm heart failure, the ARNI, and implantation of CRT, which is a strong reverse remodeling capabilities. And also it can be detected, as I've already showed, by echo parameters and biomarkers. Apart from that, CMR can be useful by assessment of lead gadolinium enhancement. So reverse remodeling and outcomes are associated, and heart failure therapies that lead to reverse remodeling also foster significant improvement in prognosis, and changes in these functions like improvement in LV ejection fraction, decrease in the LV end diastolic volume, decrease in LV end systolic volume, all are very much important parameters to guide regarding this reverse remodeling process. CRT has shown to strong impact on LV reverse remodeling. Beta blockers is already known. Renin-angiotensin inhibitors, mineralocorticoid receptor antagonists, and after the paradigm heart failure, we are aware that the ARNI, sacubitril valsartan, has a tremendous impact in the LV reverse remodeling process. Therefore, this is a paradigm heart failure study trial. I'm not going into details. Just in short, about the few facts that the 20% reduction in cardiovascular death or heart failure hospitalization with ARNI compared with enalapril, 20% reduction in CV mortality, 21% reduction in heart failure hospitalization as a primary point, and as a secondary outcome, 16% reduction in all-cause mortality when ARNI was prescribed vis-a-vis enalapril, and ARNI was superior to enalapril in reducing symptoms and physical limitations of heart failure, that is the Kansas City questionnaire form, and that implies the improvement in quality of life. Therefore, sacubitril valsartan has a significant effect on cardiovascular death and in improvement of morbidities, as well as prevention of heart failure hospitalization when patients are receiving these drugs. So reverse cardiac remodeling is very important so that the patient might not goes into certain this maladaptive process and ultimately increases their significant burden in terms of mortality and morbidity. I will quote only two studies. One is the probe heart failure study that includes the patients with LV ejection fraction less than 40%. It's an open on-label treatment with the LV. And the screening period was for 12 months. The echo-based parameters were analyzed at the baseline, 1 month, 6 months, and 12 months. Patients were prescribed sacubitril valsartan, and then ultimately, gradually, the doses were increased to 100 mg twice daily to see the effect. And blood samples were also obtained to go for NT-proBNP level. An echocardiogram was performed. And this is the chart at the analysis and from baseline to month 12. And the median NT-proBNP got reduced from 816 at the initiation to 455. And the maximum significant benefit, maximum significant reduction was noted at a very earlier period. And it was maintained at 6 months and also at 12 months. There's a very important data to support the early initiation of ARNI so that this reverse remodeling can be initiated. The primary endpoint was achieved that from baseline to 12 months, significant correlation were observed between the changes in NT-proBNP concentration and cardiac remodeling parameters. Parallel latent growth curve analysis demonstrated strong association between early NT-proBNP changes and subsequent reverse cardiac remodeling. And it was associated with the increase in LVEF from 28.2 to almost plus 9.4% at 12 months. And LV end diastolic volume got reduced from 86.93 at baseline to almost 12 point lower. And LV end systolic volume also got reduced. Therefore, it's a significant impact and on the reverse cardiac remodeling process after the initiation of ARNI therapy. And so from the analysis, the 25% of the subjects experienced an increase in LVF, 13% at 12 months. That's a very significant number because if you go by the MADIT CRT trial, we'll see that almost 15% or more improvement in the same level. So ARNI is a wonderful drug which can improve the LV remodeling process and ultimately have a significant impact in the outcome of the patients who are suffering from heart failure. And apart from the LVDB, LVSB, and LVF, LA volume index, which has been shown to be strongly associated with improvement in the remodeling process, was also got reduced from 37.76 to 7 point lower. And E by E prime, the diastolic parameter, also improved. However, it was not found to be statistically significant, but the numerically significant value was achieved. So LVMI fell from 124.77 to 107, the mean of almost 16 gram per meter square with a significant statistical value of less than 0.001. And it was seen in every subgroup of patients, all p-value less than 0.001. And reverse cardiac remodeling was comparable in almost each group, be it a new onset heart failure, ACRB naive patients, and the comparable NT-proBNP value, LVA, LVDV, LVSB, LVI, and E by E prime are significantly affected by prescribing ARNI. That's a significant study analysis. And the patients with the larger reduction in NT-proBNP and LV systolic volume by 6 months had a lowest rate of subsequent death of heart failure by 12 months. So the early initiation is very important because the significant benefit is noted at the earlier period, and it got maintained up to 6 months and then at 12 months. Therefore, it is very much imperative to start at the initial stage. That's what the point is. So to conclusion of the PROVAGEF trial is that in this study, the patients with heart failure reduced ejection fraction treated with sacubitril valsartan, reduction in NT-proBNP was significantly associated with reverse cardiac remodeling. The degree of reverse remodeling demonstrated may help to explain how sacubitril valsartan reduces morbidity and mortality in such patients, and study outcomes are consistent in subgroups, be it newly diagnosed heart failure as well as AC or ARB naive patients. And lastly, I'll talk about this evaluate heart failure study design. And this is the study which compares sacubitril valsartan to enalapril, double-blind, double-dummy treatment, open-label treatment period. Eligibility was age more than 50 years, chronic heart failure with EF less than 40%, NYHA class 1 to 3, history of hypertension, stable doses of GDMT, SBP more than 105, and no AF at baseline. And it was followed. And primary endpoint was the changes in the parameter from baseline to week 12. And the left column is showing sacubitril valsartan, and the right one is for enalapril from baseline to 12 weeks. And the secondary endpoint was the changes in cardiac structure. And if you can see the LVDB changes, LV and systolic volume changes, and LA volume changes, they'll see the LA volume changes index is significant statistically, and the other parameters were significantly numerically lower value, however has not got a significant value, but still the numerical value is pretty much lower. So exploratory endpoint in the changes in Kansas City questionnaire, that is the overall summary score at week 12 was very much significant when ARNI was prescribed. That indicates a significant improvement in quality of life compared to ACE inhibitor only. And changes in physical limitation score, symptoms frequency score, social limitation score, quality of life score, and overall summary score were very much significant. And all the data analyses from meta-analysis so far have shown a significant improvement. And this pool data from 10 studies here, you can see in the left-hand side. So the increase in the LVF following initiation of ARNI therapy, and therefore the ARNI distinctly improved left ventricular size and hypertrophy compared with angiotensin converting enzyme inhibitors, angiotensin receptor blockers in heart failure with reduced ejection fraction. And even after short-term follow-up, it is maintained up to long-term. Patients appear to benefit more in terms of cardiac reverse remodeling when treated with ARNI as early as possible and for at least 3 months. So ARNI should be on each and every prescription in patients who are suffering from heart failure with reduced ejection fraction unless and until specific contraindication exists. So that's where I conclude this session, and if you do have any question, you can ask me.